we'll just point out some important things here to start. So the first thing we talked about was the physics of blood flow. Okay, and under this, we spoke about this relationship, this equation, right? Pressure gradient is equal to flow, or bulk flow here, times resistance. And this is the equation as it applies to any liquid in a tube, okay? Any liquid in a tube. Now, we also converted this equation to our physiology, right? And then when we did that, this is what the equation looked like. Mean arterial pressure is equal to cardiac output times total peripheral resistance. So this is more relevant to our physiology. Oops. Okay, so this relationship is really important for us to understand, okay? That mean arterial pressure is directly proportional to cardiac output, and we further talked about cardiac output being the product of stroke volume and heart rate. So all three of these variables are directly proportional to mean arterial pressure. And remember, we described mean arterial pressure as being the bulk force or the driving force for blood moving through our circulatory system. Okay. So if we increase stroke volume, we increase the driving force of blood moving through our vasculature. If we increase heart rate, we do the same. If we increase total peripheral resistance, we also do the same, okay? Let's talk a little bit about resistance here. So this is kind of the second thing that we spoke about. So resistance, we said, was any impedance to blood flow, okay? Any obstruction or impedance to flow. Oops. And we talked about some factors that were directly or indirectly proportional to resistance, right? So if we increase resistance, which by the way is decreasing flow, right? Based upon this relationship here, if we were to rearrange this equation, flow and resistance are inversely proportional. So if we increase resistance, we also decrease flow. Okay, and we talked about some factors that could have that effect. The first thing that would increase resistance or decrease flow is the length of the vessel. So if we increase the length of the vessel, we increase resistance, we decrease flow. The second thing was the radius of the vessel. If we decrease the radius of the vessel, we increase resistance, we decrease flow, right? This is going to be inversely proportional to relationship. Increase the radius, decrease the resistance, decrease the radius, increase the resistance. And if you remember here, the radius was really dependent upon the state of the smooth muscle that lines that radius, especially in arterioles where we see most of the resistance in the vasculature. So someone is asking here, if I increase TPR, does mean arterial pressure increase too? Yes, that is true. Again, based upon this relationship, increase in TPR increases mean arterial pressure, okay? The third factor that is influenced here as a part of resistance is the viscosity of blood. And this is going to be directly proportional to resistance. If I increase the viscosity of blood, I increase the resistance. I make it harder for flow because the blood is thicker here, right? So increased viscosity of blood will increase the resistance or decrease the flow, okay? So we want to think about all these factors in this way, but also think about them in the opposite, right? If I decrease the length, I decrease the resistance, et cetera, okay? The third thing we spoke about here was basically the difference between the systemic and the pulmonary circulation and how that equal to a constant or uniform flow. So the systemic circulation versus the pulmonary circulation, and how both of these led to a consistent flow in both of these systems or both of these circulatory regions. So in the systemic circulation, we had a high pressure gradient and a high resistance. Whereas in the pulmonary circulation, we had a low pressure gradient and we had a low resistance, okay? And both of these things led to consistent or equal flow in both of these branches of the circulatory system. So both of these lead to equal flow in both units. Okay, high pressure gradient, high resistance, low pressure gradient, low resistance, equal flow to both of these circulatory regions. Alrighty. I'm seeing a question here. Is the entire physics of blood flow equation directly related? I'm not sure what that question means, but it's another way of expressing the equation that's relevant to our physiology, okay? So it's just a simplified way of expressing this equation, which is more meaningful to our physiology. Okay, I hope I answered that, what that question was getting at. All right, any questions here? We're gonna move right along to some other topics here. If you've got any other questions, you can leave those in the chat. And again, these drawings will be up, so don't worry about rushing to recreate this as we go. If you miss anything, these drawings will be up, right? Okay. The second thing we'll look at here is the branches of the vasculature, right? The branches of the vasculature. And I asked you at the beginning to create this kind of study table to kind of make a note of the important parts of each branch of the vasculature. So we'll do that here. All right, okay. So we'll start with arteries, arterioles, capillaries, venules, and veins. We'll kind of lump those together, not much to say here. And then lastly, lymphatics. Again, not too much to say about lymphatics. Okay, let's just put some lines here. And then we'll fill these in. All right, so as far as arteries, the first thing we said about arteries was that they have a thick elastic wall. All right, thick elastic wall. We also said that they have decreased compliance and they have decreased resistance. Okay, and both of those things led to this, this description of them being a pressure reservoir. Okay, a pressure reservoir. In other words, they can store a lot of pressure in their walls to be used for the recoil of blood during the filling phases of the cardiac cycle, right? So they're going to give continuous pressure because they can store or capture that pressure in this thick elastic wall. And this wall is also described as having low compliance. And so we said that arteries have a large pressure change. So a large pressure change for a small change in volume. Okay, and they also have this ability to recoil, really important, also ties into that compliance, that low compliance, okay? High elasticity, low compliance is what that recoil means. So that's kind of all we said as far as arteries, okay? Let's move on to arterioles, kind of the main important parts or components of arterioles. So arterioles have the highest resistance, right? 60% of our TPR is found in arterioles. They also had the highest drop-off in pressure. Okay. As far as regulating arterioles, we spoke about the radius, right? The radius of that arteriole, which is really a reflection of the smooth muscle within the arteriole that was dependent upon a couple of different factors. One is going to be the tone, right? That tone of smooth muscle. Two was vasoconstriction. Okay, and remember we said vasoconstriction is going to decrease the radius or increase the TPR. Oops. Vasoconstriction increases the radius, decreases the radius and increases the TPR. Vasodilation was the third way that we can regulate the radius here, and that's going to be the opposite, right? So vasodilation of that smooth muscle, which does the opposite, it's going to increase the radius or decrease the TPR. Alrighty. And then the next thing we spoke about was some mechanisms of actually regulating flow here. And so that involved intrinsic mechanisms as well as extrinsic mechanisms. Let's kind of squeeze this in the bottom here. So we had intrinsic regulation. All right, and that involved three different mechanisms. We had active hyperemia, and I don't really have space to kind of explain this here, but active hyperemia, if you remember, was basically increased metabolic demand in tissues or decrease, right? It can happen in either direction. And then we would increase flow or decrease flow depending on that metabolic demand. So if we had increased metabolic demand, we would see a buildup of CO2 and other metabolites. We would see decrease in oxygen. That would be an indicator to adjust our radius size, right? To vasodilate, bringing in more blood. And then if we had the opposite, we'd see vasoconstriction. The second mechanism here was reactive hyperemia, right? Reactive hyperemia. And this was kind of the same outcome, the exact same outcome as active hyperemia, the only difference being the cause. In active hyperemia, we had an increased metabolic demand. In reactive hyperemia, and I'll put that in brackets here, we had a disruption to flow, right? A disruption to flow. So it's not that the tissues are using more oxygen and generating more metabolites, it's that they're just not getting enough of that oxygen and of the flow to clear those metabolites. And so we're now seeing that as a buildup because of that disruption in flow. So that's going to be the second mechanism, same outcome, different cause. And then the third mechanism here of intrinsically regulating flow was myogenic feedback. Okay, and again, I'm not going to get too deep into the details here in the interest of time, but myogenic feedback, we said, was that if I increase flow, the vessel wall stretches more, the reaction is to vasoconstrict. If I decrease flow, the vessel wall doesn't get that stretch, the reaction is to vasodilate. So just the opposite reaction based upon stretching or not stretching of that arterial wall. All right. Hope that's clear there. And then lastly here, as far as arterioles, we had extrinsic mechanisms of regulation. This was anything outside of the arteriole itself. So think about hormones, think about the nervous system here, specifically the sympathetic nervous system. And the sympathetic nervous system had a couple of different players. So we had norepinephrine, and norepinephrine can bind to an alpha receptor, and that's going to cause vasoconstriction. In most of our tissues, remember, there's the exception here of heart and muscle, right? Heart and muscle mainly, and then brain is kind of just not obeying this rule, okay? We also have Epinephrine, and epinephrine is a little bit more complicated. Epinephrine can bind at low concentrations, so I'll put a down arrow here. Low concentrations, epinephrine binds to beta receptors only. That brings about vasodilation to heart and muscle. I'll put heart and muscle. And then epinephrine at high concentration causes both of these things. Vasoconstriction everywhere else, but vasodilation to heart and muscle, right? So I'm just going to put both responses here so we can understand. So it's going to kind of go over this here one more time. Norepinephrine, alpha receptors, vasoconstriction everywhere except heart and muscle. Epinephrine, low concentration, beta receptors only, vasodilation only to heart and muscle. But then epinephrine at high concentration has both of these effects. It's going to cause vasodilation to heart and muscle. It's also going to cause vasoconstriction everywhere else, okay? All right, let's quickly move on to capillaries. Capillaries, we said, have a thin wall, right? Really important for their function, which is diffusion. And if we have enough time, I'll get into the gas exchange, an example of those Starling's forces in a bit, but this is mainly the role of these capillaries at gas exchange or diffusion. They also have the greatest cross-sectional area. In other words, if we were to combine the total cross circumference of all capillaries, they have the widest diameter in terms of a combined diameter than any other branch of the vasculature. We talked about three types here, the main one being the continuous. And these continuous had little or small pores. And so there was no cellular or protein movement. Okay, we talked about two other types, but the main one was going to be that continuous, and the small, the pores between those endothelial cells were really, really small, such that no cells or no proteins can go through those pores. Okay, the next thing we spoke about here was regulation of capillary flow. And that involves three different mechanisms. We had the meta-arterioles. We had the arterioles themselves. And then we had the pre-capillary sphincter. Okay. And the last thing, again, I'll touch on this a little bit if we have enough time, hopefully towards the end here, but the Starling's forces was the only other important part of capillaries. Alrighty. Let's move on to venules and veins. So venules, we said minimal diffusion happening in venules specifically. Okay. And then more about veins here at the bottom. Veins had some of the opposite properties than arteries, right? They had a large internal diameter. Large internal diameter. They also had a increased compliance. And then they also had valves. Okay, so veins are going to be the opposite of what we saw in arteries. They have a little elasticity or little recoil, and they have a lot of compliance. They can adhere or accommodate larger volumes, and so we describe them as being a volume reservoir. All right, a volume reservoir. Okay, and so this simply means that veins have a small pressure change for large changes in volume. Oops, for large changes in volume. Okay. The last couple of things we spoke about as far as veins were the four mechanisms that helped with venous return. Okay, the skeletal muscle pump, working together with the valves, right? We also talked about the respiratory pump. Okay, and then we spoke about venomotor tone. And I'm getting a lot of questions about why venomotor tone decreases compliance, okay? And if we think about what compliance means, compliance is the obedience of the vessel. And so the vessel is normally, the veins that is, are normally able to withstand or accommodate volumes without any give back, any push from that wall. There's very little pressure stored in the wall of a vein when it accommodates these large changes in volume. Venomotor tone is slightly decreasing that compliance. It's making the vessels a little bit more rebellious, if you will. They start to give a pushback onto that blood. And that is because of that smooth muscle that's within the vein, the wall of the vein, that now constricts. And when that smooth muscle in the wall of that vein constricts, it actually gives a little bit of pushback onto the blood. And that's what we mean by slightly increasing the compliance, which is needed to encourage blood along back towards the heart. So understanding why venomotor tone decreases compliance really relies on you understanding what compliance is and the fact that veins are really compliant. They're usually really obedient. If you put a liter of blood into a vein, it's going to just accommodate that liter without any pressure being stored in the wall the way that we see in arteries, okay? But having that constriction of the smooth muscle, that venomotor tone, slightly gives a little bit of pushback, a little bit of rebelliousness, if you will, of that vessel wall onto the blood, which encourages venous return, okay? And then the final factor here, which I may not have space to put, oh, I do, is the blood volume, right? Blood volume, a long-term regulatory effect with the kidneys that we spoke about, right? So it's gonna be much more long-term in terms of regulating venous return. Last thing here that we'll say about this is the lymphatics. So lymphatics are these clear, lymphatics help to clear the excess filtrate, clear excess filtrate from the blood. So we talk about that excess 3 liters per day that's filtered out into the interstitial fluid. And so lymphatics help to return that 3 liters per day back into the circulatory system by bringing fluid back to the right side of the heart. Alrighty. They also had valves, and they also played an immune role, right? We had these lymph nodes that have macrophages that help with this immune role. Okay, so that's it as far as the branches of our vasculature. In our last minute here, I'm just going to quickly touch on the Starling forces as an example, and then we'll call it a day. Whatever I don't finish up, guys, I'll put in a recording and I'll just upload it to Brightspace. There are also some additional practice questions that I'd like to share. And I'll, again, put those in a recording and upload them to Brightspace. Okay, last thing I'll touch on here is that Starling force example. In our remaining minute here. So the Starling forces, we talked about the hydrostatic force being a push, the osmotic being a pull, okay? And then this is the first part of the equation. The second thing is the general direction of filtration. So filtration we described as being a movement of fluid out of the capillary. And our forces that favor filtration, this is going to really help you understand the calculation that will come on your exam by understanding which forces favor filtration. So the forces that favor filtration are the capillary hydrostatic pressure and the interstitial fluid osmotic pressure, okay? Now let's just plug some values in here so we can quickly practice a calculation. The second, oops, I'm scratching everything out here. The second net direction is absorption. okay? And we said this is a net movement of fluid into the capillary. And again, our forces that favor absorption are going to be the other two forces. So the interstitial fluid hydrostatic pressure and the capillary osmotic pressure, right? And again, let's plug some values in here so we can practice a calculation. So if we're to calculate our net filtration pressure down here, that's filtration minus absorption. And so that's going to be our forces that favor filtration. So 40 plus 10 minus our forces that favor absorption. So 15 plus 15 equals 50 minus 30 equals 20, okay? And so because one, this is a positive value, but also two, filtration is bigger, we know that this favors filtration.